Is it working? Hello? Good afternoon, ladies and gentlemen. I know it is very close to lunchtime. We all are very hungry. But I think this is the best time to discuss about the drug in detail, which makes you eat less. So it gives me immense pleasure. So I'm Dr. Gautam Das. I work as a consultant endocrine in Imperial College in Al Ain in Abu Dhabi. So it gives me immense pleasure to welcome back Professor Arya again. And you heard him this morning, so I'm not going to go through his illustrious CV again. He's a world-renowned personality in the field of obesity. And in this symposium, he's going to enlighten us about embracing a very holistic approach in managing obesity in adolescents and adults, and that too with Semaglutide 2.4 milligrams. So without any further ado, I would like to welcome Professor Arya back to the stage again.
So thank you very much for that introduction, and I realize I stand between you and lunch. I'd like to start by thanking Novo Nordisk for sponsoring this, because this is actually supposed to be a Novo Nordisk sponsored symposium, so the focus here is going to be on semaglutide, which you've just heard so much about, and I have to thank Dr. Ryan for setting up the stage so beautifully. Talking to us about this whole new class of medications, the GLP-1 analogs and its derivatives, and tirzepatide actually is a derivative because the backbone of the tirzepatide molecule is actually GLP-1, and is going to probably set the stage for a lot of advancements, a lot of very rapid advancements in our ability to treat obesity. So I want to focus on semaglutide. Here are my conflicts of interest, as you've seen. Now, I'm not going to bore you with the fact that the reason we are all interested is obesity, because obesity, as we have heard on several times, and it's the motto of the whole conference here, is that it affects virtually every organ system. And as was pointed out briefly here by several of the speakers, it doesn't really matter what area of medicine you practice. You can be doing, gastroenterology, you could be doing cardiology, you could be doing psychiatry, you could be doing fertility. It doesn't really matter, because you are going to be seeing people who have obesity in all of your practices. And so a fundamental understanding of how to manage obesity, the pathophysiology of obesity, how to deal with patients who have obesity, how to meet their expectations, how to deal with all of the things that I talked to you about earlier this morning, those are basic skills that I think every practicing physician, irrespective of your discipline, probably has to be familiar with. Now, having said that, we have also learned that we have to go beyond a purely BMI-centric view. I mean, those of you who have been following my own work, when we came up with the Edmonton obesity staging system, the reason we had to come up with that staging system was because we have known for a long time that body mass index is really not seriously a measure of health. It works great at population levels. When you do population studies, obviously people who have higher BMIs, they have more medical problems, they have lower life expectancy, we know that. But when you bring this down in your clinical practice to a single patient who's in front of you, BMI is really not very helpful. So I can have someone with a BMI of 35 who has fatty liver disease, they have diabetes, they have sleep apnea, they have pains in their knees, maybe they have fertility issues, and then I have the next patient, BMI 35, no problems. Triglycerides are normal, blood pressure is normal, no sleep apnea, no snoring, they feel fine. So when you bring BMI down to an individual level, it is actually not very useful to help you identify which are the patients who are actually in need of medical treatment. So this is something we proposed 10, 15 years ago. And it has taken a long time for now the guidelines, the new guidelines, the Canadian obesity guidelines, for example, actually very specifically say that BMI should not be used to diagnose obesity. BMI should be used to screen people, because for people who have higher BMIs, their risk of having obesity increases. And so you can use it as a screening tool, but but the diagnosis of obesity is a clinical diagnosis. I have to see the patient, I have to do some lab work, I have to look at their history, I have to ask them how their, how their health is. And then based on that assessment, I can then say this is somebody who probably has obesity and is somebody who's going to need obesity treatment. Now that non-BMI centric view is now being adopted by several other guidelines, and we've just seen the, here's a consensus document, but we've also seen that the recent recommendations of the European Association for the Study of Obesity, those were published in Nature Medicine just a while ago, they have made the same point. They say that yes, we can use BMI as a screening tool, but we need to make the clinical diagnosis of obesity based on the presence or absence of actual impairments in health or impairments in well-being. Now, we're all waiting for the publication of the Lancet Commission report. They are going to have a different terminology, but the idea is going to be the same, that we are not going to be using BMI as our sole definition for making the diagnosis. Now, when we talk about all of these guidelines, it is also becoming clear that although the regulators are still using the term weight control medication or weight loss medication, we now recognize that it's not really about weight loss. We just heard that from Donna. Donna showed you that it wasn't the people who lost the most weight who had the most benefit in the SELECT trial. In fact, even people who lost very little weight had benefits. Now, we have known this from the surgeons, actually, because even in the surgical literature, when you go back, what you see is that in most of those outcomes, which the surgeons have been able to demonstrate, there very often is not a close relationship between the amount of weight people lose and the benefits that they get. And this is true for cancer reduction, this is true for mortality, etc. So focusing alone on how much weight do I lose may not actually tell you who the patient is who's getting the most benefit. And that's, which means that we need to start focusing on health outcomes as a measure of success. And I was very happy to see that the panel that is going to monitor the success of the UAE obesity program rollout is not only going to be looking at our patients losing weight, but is actually going to start reporting on a whole panel of outcomes. And I was just recently the chair, and many of you in the room might have been part of the panel over the last 2 years. We have worked for, with an organization called ICHOM, ICHOM, and we are about to publish what we believe should be standardized outcome measures to really see whether our obesity treatments are working. And I want to make this very important distinction between weight loss and managing obesity. Weight loss you can get at any weight loss center. The focus there is losing weight. You go there, you pay money, you lose weight. That's weight loss. What we are talking about here, and what I want you to think about as of yourself, we are not doing weight loss. I'm not a weight loss doctor. I'm an obesity doctor. We practice obesity medicine. And the goal of obesity medicine, to practice obesity medicine, you have to be a health professional. Weight loss, anybody can do weight loss. See, my Uber driver can give me tips on how to lose weight. Okay? But my Uber driver is not doing obesity medicine. He's never been to medical school. So we have to make that distinction. So when you say you are running a weight loss center, I said, that's good for you. I prefer you call it an obesity center. Okay? So we have to make that distinction. Now, we've already heard a lot about semaglutide. I'm not going to repeat this. I just want to remind everybody that when we talk about treatment with these medications, we call them medications, but what we're really talking about is hormone treatment. When I say that, the endocrinologists get very happy because it's, okay, hormone treatment, endocrinology, that's nice. And the reason we have to remember that this is hormone treatment, and that is also what I tell my patients. I tell my patients, when you take these injections, when you take a GLP-1, you're actually using a hormone. That makes some patients very happy because they always think that their obesity is because of hormone problem. So now I'm giving them a hormone, they're very happy. They say, okay, finally somebody's using the right medication. But we have to remember that these are very, very powerful molecules. And so, as Donna pointed out, as we start using these molecules more and more in our practice, we have to understand the endocrinology of these molecules. And like most hormones, they work on multiple organs. And that's very important for us to understand. Now, in the context of weight loss, why do these medications reduce weight? And the answer is very simple. They reduce weight because they allow you to sustain a negative energy balance. What does that mean? What it means is that there's going to be less calories going in than going out. That's negative energy balance, and that leads to weight loss. And these medications allow you to sustain that. Now, there's quite a dramatic effect in terms of reducing weight loss. If you think about what is the natural function of GLP-1, GLP-1 gets released every time you have a meal. When I have a meal, my GLP levels go up. They tell my brain I've eaten. So I get a sense of satiation, and that sense of satiation lasts, and we call that satiety, and that satiety lasts. Now, if I inject GLP-1, what does the patient tell you? What does the patient feel? The patient feels like they have just had a large meal, and so they are full. So now when they want to eat, they find they cannot eat so much. In fact, they don't even want to eat so much. Right? And we used to hear that from our bariatric surgical patients. Now we are hearing from our medical patients. So the reason that we get weight loss with these medications is because of reduced food intake. And as I said previously this morning, this is pharmacological behavior change. Right? We don't have to educate the patient to eat less. They will automatically eat less because when you feel full, you're going to eat less. All right, so the mechanism of action is, in the context of obesity, is in reduced energy intake, which means that patients are less hungry. And because they're less hungry, there is also less activation of the hedonic system, which means that they have fewer cravings. Now, we do have medications which will specifically address the hedonic system. So I know that in some of your countries, you have a medication which is a fixed combination of bupropion and naltrexone. That medication very specifically addresses the hedonic system. Semaglutide and GLP-1s, they also address the hedonic system because they reduce hunger, and when you're less hungry, then the hedonic system actually has less activity. And so it also reduces cravings, okay? Now, with these medications, for the first time, we can not only do the regulatory trials. When you have a new medication and you want to get your approval from the FDA and the EMA, the health authorities to approve the medication, you have to show them data, and they have requirements. And they say, okay, you have to show us you get at least 5% weight loss, it's sustained over 12 months, it has to be at least 2,000, 3,000, 4,000 people. Those are regulatory trials. And so all the companies that are developing these medications have to do regulatory trials. But what these medications also now allow us to do is something I said earlier, is for the first time we can actually now randomize controlled trials where we can look at other outcomes that go beyond weight loss. And that has become very exciting because now for the first time we can actually demonstrate that there are health benefits of obesity treatment, which so far only the surgeons have been able to show that. Now we can start showing that, and I mentioned this morning, and you saw it on the slides of Donna Ryan just now, that we are starting to see results for all kinds of, so it's not cardiovascular protection alone, it is HFpEF, it's HFrEF, it's hospitalization, it's fertility, and it's all of those other issues. And I think this is going to make it also very difficult for the insurance companies to say we will not pay for treatment, because the more you show outcomes, the more pressure is there to say, okay, well then maybe we have to pay for this. All right. I'm an adult physician. I have no training in pediatric medicine. And I was running the adult obesity clinic, and not far from my clinic, there was the pediatric clinic. And I always felt very sorry for those guys. Because in adult medicine, at least we can talk to the patient, we can do the education, I can get the psychiatrist, I can try medications, I can send the patient to the surgeon. It was not great, but at least for the adult patients, I had treatments that actually worked. In pediatric obesity, my poor colleagues, they had no medication, they couldn't send the guy for surgery. You can't talk to the patient, you have to talk to the parent. Much more difficult situation. And when we look at their outcomes, see, the adult outcomes were not good. The outcomes in pediatric obesity were even worse. So I always actually felt very sorry for those guys, and I was saying, thank God I'm not a pediatrician and I don't have to deal with that. Because we don't have good treatments for pediatric obesity and adolescents. But we have a huge problem with adolescent obesity. And so it is only logical to say, well, if these medications work in adults, do they also work in younger individuals? Because we have nothing there, right? We have behavior, and in some countries I know they do surgery on kids and adolescents. In Canada, we don't operate on adolescents, okay? So there's no treatment. So one of the studies that I just want to bring to your attention here is the teen study, which is really the first study that has looked at the use of anti-obesity medications or obesity medications in younger individuals. And this is the teen study, so you can see the study here. Patients are up-titrated, randomized, double-blind control, lifestyle intervention, etc. 12 to 18 years old. These are adolescents. What was the result? The first result is the amount of weight loss you get in adolescents, when you look at this as percentage body weight, is exactly the same as adults. So you're getting the exact same response. And remember, some of these adolescents are actually as heavy as adults, right? They may only be 12 years old, but they're 70 kilos, 75 kilos. So the first thing we can say is these medications work in adolescents, and you can get the same degree of weight loss that you would see in adults. You remember the number 16, right? I pointed that out this morning. Here's an interesting analysis. When you categorize the individuals based on the class of obesity, we have classes based on BMI. I'm not a big friend of BMI, but if you use BMI classes, we have class 1, class 2, class 3, etc. So what you see on the slide is actually that when you look at the semaglutide, when you look at the placebo group, you can see that very few people or very few participants will change the obesity class. Look what happens in the treatment group here. Almost half the individuals move from an obesity class to the overweight class or even to the normal weight class, right? It doesn't show BMI because you know that in adolescents, we don't just use BMI, we use Z-scores, slightly more complicated. But the bottom line is that not only do these medications work in adolescents, but you can actually bring a significant proportion of those adolescents into a range that would be considered almost normal weight. Now, why is that important? That is important for one important reason. See, in adults, when somebody is, 100 kilos, and I treat them successfully, we know that the homeostatic system will always try to bring them back to 100 kilos. Which means that in adults, I have to continue the treatment. If I stop the treatment, if I have a patient who's 100 kilos, I put them on the medication, they lose 30 kilos, they are 70 kilos, I stop the medication, what happens? They go back to 100 kilos. But if I have a 12-year-old who is 70 kilos, which is too much, I treat them, and their weight goes down to, say, 50 kilos, 20 kilo weight loss, which is nice, but that he continues to grow. So there's a chance that even if I take this patient, when this guy becomes an adult, they're not going to be a 100 kilo adult. They will be maybe a 70 kilo adult, which is for an adult is not so bad, right? So the concept in adults is, well, we have to do lifelong treatment. In teens, there's a hope that if I start early enough and I prevent the weight gain early on, at some point as they get older, I may be able to take away the medication and I end up with an adult who does not have obesity. Right? So that is a concept. Now, we don't have the data for that, but at least there's a hope that maybe obesity treatment with medication in adolescents may not have to be lifelong treatment if we start early enough. Now, of course, if I'm treating an adolescent who's already 120 kilos, that guy will probably also have to continue on treatment, right? Because 120 would be too much for an adult. So as long as the adolescent's weight is below what would be considered too high for an adult, there's actually hope that if I can stop the weight gain, reduce the weight gain, I might actually end up with an adult who may not require obesity treatment. So these are the baseline characteristics. I don't want to bore you with this. As you can see, the BMIs were quite high, 38. That's pretty high. As we get into the adult studies, so that is the teen studies. Now, by the way, tolerability, the side effect profile was exactly the same as in adults, right? The nausea, the nausea, the cases of vomiting, gallbladder, it was pretty much the same, right? So the side effect profile in teens is pretty much the same side effect profile in adults. Okay, let's move on to the STEP trials. So the STEP trials is a whole series of trials that were done with semaglutide, different populations. Here you can see step 1 to step 7. Actually, I think now there's almost 20 STEP trials in all kinds of populations with all kinds of outcomes. I only want to show you this one. This is the step 1 extension, because this is the one which for adults and probably also for many teenagers is the important one. When you stop the medication, the weight comes back. And a lot of people look at this slide and they are very disappointed. And they tell me, yes, okay, so the stuff doesn't work. I said, what do you mean it doesn't work? Medications only work when you take them. Right? There's no medication that I know which works when you don't take it. Right? So, and then people get disappointed. And then I say, you have still not understood the concept of chronic disease. And I said earlier, I have not, I have never cured a case of type 1 diabetes. Right? I have never cured a patient who has coronary artery disease. I have never cured a patient who has chronic kidney failure. We don't cure those diseases, we manage those diseases. And we manage those diseases with medications which we hope our patients will continue taking. So the idea that I can, at some point after losing weight, just stop the medication and somehow magically I will keep the weight off, that means you have not fully embraced the concept that we are actually dealing with a lifelong problem. Now, there will always be patients. I see those patients in the hypertension clinic. I have some patients in the hypertension clinic, they treat their hypertension maybe for 1 year, 2 years, and then they come off the medication and somehow they manage to, control their, but they are few. Those are exceptional cases. And you probably have seen it even in your diabetes clinic, that there will be some patients, they have diabetes, you treat the diabetes for a few years, you stop the medication, and somehow still they manage. Right? But these are few cases, these are individual cases. The average person is going to go up, right? So my expectation is that when I stop the treatment, the problem comes back. And so in clinical practice, when patients ask me, so doctor, how long do I have to take this? My standard answer is you have to continue taking till you decide that you want to gain the weight back. Then you can stop. Okay? And I'm serious about it. It sounds funny, but I'm serious about it. If you decide, no, I want to regain the weight, be my guest, stop the medication. Okay? And think about it. Why are we even discussing stopping the medication? There's only one reason why we are talking about this. Money. If this is free or costs the same price as metformin, nobody will be discussing discontinuation or tapering the dose or intermittent treatment. Why are we discussing on any of this? Because of cost. And as I said this morning, cost is going to change. It's a question of time. 5 years, 10 years from now, we will no longer be talking about intermittent treatment or tapering off. No, it'll be, right? It is cheap, it is available, people have access. Why would I stop anybody? Okay? Then people say, well, what about the long-term effects? First of all, GLP-1 is not new. We saw the slide, exenatide has been more than 20 years. Diabetes patients have been taking these medications for how long? We have not seen any problems. If it is okay for someone with diabetes to take these medications, why should it not be okay for someone with obesity to take it? Right? So I'm quite optimistic that even the long-term use, we are not going to see major problems. Okay? If it is managed properly. Okay, let's look at body weight change here in this study. And so this was the step 4 trial. So the way the step 4 trial was, everybody starts with semaglutide, they lose weight, and then they get randomized to either continuing on semaglutide or stopping on semaglutide. So the first thing you see is the guys who stop, weight comes back. I showed you that. But what is also interesting is the guys who continue, they continue losing weight. And the duration of weight loss, how long, when do you see the maximum effect of these medications? It's an important point. In most patients, you do not see the maximum effect till about 6 to 12 months of taking the medication. Remember the surgical patients. When do you see maximum weight loss in surgical patients? After 12 to 18 months. right? So these patients are still losing weight, even, so you're looking at 1 year, and that is also something we have to explain to our patients. See, because our patients, they start here, then they take it for 4 weeks, they only lose 3 kilos, they say, this is not working, and then they stop. So we also have to tell our patients that, no, you have to continue, because the maximum effect you will actually see after 12 months, maybe in your case, maybe even longer, right? So you cannot decide you can decide to stop the medication in patients where there is no response, right? If after 12 weeks, no response, patient has not lost any weight, then probably it's not working for that patient. Okay, but if patient is losing weight, that weight loss is probably going to continue for at least 12 months. And that is important. It is also important to tell the patient, at some point you're going to stop losing weight. See, nobody continues losing weight till they disappear. If your patient is still losing weight over here, you have to start thinking maybe there is another reason for weight loss. Right? Maybe there's something else going on, and then because unintentional weight loss, that is, see, when you run an obesity clinic, one of your challenge, everybody in the obesity clinic is trying to lose weight, right? So finding the patient in whom there is more weight loss than you would actually expect is not very easy, right? Because when you look at the health impact, somebody who's losing weight and you don't know why is never a good sign in medicine, right? Think of any patient who comes to you and says, doctor, I'm losing weight, but I don't know why. There is always a medical problem, and usually the medical problem the prognosis is probably not very good. Those guys you will also see in an obesity clinic. So the patient is happy, oh, this is a great treatment, I'm losing so much weight. If the weight loss is too good to be true, then you should be screening the patient for other issues. You should be asking like night sweats, and maybe the patient needs a colonoscopy, and maybe the patient should be checked for tumor markers and other stuff going on. So that's always important to remember. When patients lose too much weight, is usually not a good sign. Okay. This is the responder stuff. Like I said, I cannot tell you what the maximum weight loss is, but when people don't respond early, usually the long-term effect is also going to be less. And this is a study that shows that when you take people, the early responders, so the people who respond early, if you keep them on the medication, they go on to have, in this case, 20 kilos. The guys who don't respond, even if you leave them on the medication, they probably doesn't go anywhere. Okay, so your best predictor is early on. Is the patient losing? And patients will tell you. I mean, you have all seen patients now. Within the first week, even at the lowest dose, patients will tell you, oh, there's something different, right? They will tell you. So you can usually identify people quite early. And what I always remind everybody is, see, there's one big advantage we have in medicine, which the surgeons don't have. We can try medicine. You cannot try surgery, right? If I decide to have a gastrectomy, I cannot change my mind after the gastrectomy, right? Stomach is gone. Medication, we have the luxury of trying the medication. We can change the dose, we can titrate the dose, we can switch, we can do combinations. We can find the best treatment for our patient because we can try things, right? And that is also important to know, that we have this flexibility. Now that we have many different therapeutic options, we have the option of trying different medications, different doses, different titrations, different combinations. We can do that in obesity medicine now that we have that luxury. The surgeons don't have that luxury. They do one operation, then they can only do another operation where they tighten it even more or shorten the loop or do whatever they do. They can't just try things, right? In medicine, we can try stuff. Okay, long-term weight management, this is a trial. This goes on we know the long-term effect. You just saw Donna didn't show you, but in the SELECT trial, the weight loss was maintained over 4 or 5 years, right? So we know that when you continue the treatment, you will be able to sustain the weight loss over time. Cardiovascular risk factors, we've seen it. Waist circumference goes down, systolic blood pressure goes down, diastolic blood pressure goes down, inflammation, C protein goes down, HbA1c goes down, fasting plasma goes down, insulin goes down, triglycerides, I mean, everything moves in the same direction. Right? There is nothing here which goes in the wrong direction. You say, okay, maybe that is going to be a problem. Right? Everything is moving in the right direction in terms of all of this. Okay. Knee osteoarthritis. One of the problems we have when you run an obesity clinic is that people will come to the obesity clinic and they'll say, why are you here? They say, I have to lose weight. They say, why do you have to lose weight? Because my orthopedic surgeon says I have to lose weight so I can get new knees. How many of you have patients like that? Everybody, right? We all have patients sent by the orthopedic surgeon who says you have to lose weight so we can do the knee. Because we also know that the knee is the most sensitive joint for body weight. It's not the hip, right? It's the knees and it's the plantar fasciitis, which, by the way, we need to study. Okay, so this is an osteoarthritis study. These are studies. This study was done. Actually, I think it's the first randomized controlled trial with an obesity medication in patients who have knee osteoarthritis. And what the study shows is weight loss is about, weight loss, by the way, was about the same, 16%, right? Here's what happens. WOMAC. WOMAC is the Western Ontario McMaster pain score. So the orthopedic guys and the rheumatology guys, they, all the joint people, they like to use pain scores as their primary outcome because that is the problem for the patient, right? So what you see in the study here is that there is a significant reduction in pain scores. And when you talk to orthopedic surgeons about this, they say, that is pretty impressive. That is a very impressive result. And when you say, what is the functional score? Function improves. Less pain means I can do more movement. Here's an pain medication use. The use of pain medication goes down. Right? So this is, actually, I think this is the first time we have a non-steroidal treatment that will reduce pain in patients with osteoarthritis. I think the study is not getting enough attention because this is the first time we actually have a medical study that shows that there is a medical treatment, not using NSAIDs, that reduces pain in people who have osteoarthritis. Okay. Safety profile, I don't want to bore you. We all know the safety profile. We know the contraindications. We know the indications. And it has been established in all kinds of population. Type 2 diabetes, adolescents, we have done the elderly, we have done patients with heart failure, you have the high-risk cardiovascular patients, so we know the medication is well tolerated. Of course, there are side effects. Of course, there are contraindications. But if we follow those, this is actually not so difficult to move. So when we talk about the indications here, obesity is indicated for obesity. This is the dosing schedule. This is the dosing schedule that was usually used in the trials, and so because it was used in the trial, it is also in the prescription information. But in clinical practice, I can tell you, in my own practice, I am quite flexible. I usually titrate based, if the patient is still having symptoms, nausea, etc., I stay on the same dose. If the patient is losing weight, I also stay on the same dose. Usually I increase the dose when the patient is not losing weight, I go to the next dose, right? So this is the recommended criteria based on the clinical trials, but in clinical trials we know, but in clinical practice we know that we can individually tailor the dose escalation. And to be honest, not every patient needs the highest dose. Okay? Okay, so in conclusion, Semaglutide, I think we are all comfortable with this molecule. It's been around now for quite a while. It's the molecule that has the most data now because it's the oldest molecule. Of course, tirzepatide is also now coming with data, and then there will be new ones also coming with new data. But right now, semaglutide is the one that has the most data. It's the only one with data for cardiovascular outcomes. It's the only one with data for knee osteoarthritis. It's the only one with data in teens. The tirzepatide guys will also come, but they are not there yet. And so I think, as you can see, we are entering a very exciting phase in obesity management, and I hope you get my excitement because For a long time practicing obesity medicine, I felt like I was only working for the surgeon. I was preparing patients for surgery. I was looking after patients after surgery. Now, finally, I can start competing with the surgeons in terms of efficacy and outcomes. And I think we are entering a very exciting area in obesity medicine. So thank you again for Novo for hosting this, and enjoy your lunch.
Thank you, Professor Arya. Thank you to Novo for organizing this symposium. We're already running pretty late. I think we are going to assemble here at 2:30. But if anybody has, I'm going to allow only one question, one burning question before lunch. So yeah, gentlemen.
Could I ask you, please, the example you used for those BMI with 35 with no medical problem, and the other one who is having a lot of severe problems. Could it be a matter of time that this guy with 35, that he didn't have enough time of obesity, then he didn't develop it yet,
Yeah.
which says about clinically normal obesity, which is the term which I don't believe, but what do you think?
Okay, very simple answer. Any decision to treat, you have to look at risk-benefit ratio. The sicker the patient, the more benefit. So if I have a patient who has a low risk or low medical problems, then of course the risk of treatment may be too high. So I have to decide treatment, who do I treat based on risk-benefit. If I expect big benefit, then I'm prepared to take bigger risk. Make sense?
Prof, there's one last
Small question.
gentleman.
Yes, sir.
There you go.
In type 2 diabetes, we have a term of diabetic remission. In type 2 diabetes, we have a term called diabetic remission.
Okay?
He no longer take AV metformin, yes?
Yes.
So when I stop any any obesity drug, he gain again. So is obesity in remissionable disease?
Yeah. So the question there, of course, is these are medications that are also approved for diabetes treatment. So the
Yes.
question of diabetes remission or not with these medications is difficult. Right.
I ask about obesity. Obesity remissionable or irremissionable? I can be
I think he's trying to say,
obesity free or not?
Can we achieve obesity remission with these classes of drugs?
Obesity remission, yes.
Yes. This is the
Not if you
question.
stop the medication.
So
Right.
I will continue forever.
So I don't speak about obesity remission, I speak about obesity control. I'm
Yes.
controlling the obesity, but I don't call it remission,
Yes.
Okay.
So
Even
patients
for
with
my-
obesity have to live with it.
pretty much.
Okay. Thank you.
Okay, thank you. I'm going to wrap this session. So we are reassembling here at about 2:30. So see you then. Thank you. Thank you.